The topic for the panel is opportunities for improving health care, and as you've heard, again, this is a critical part of effective health care reform, both in the short term and the longer term. I'm very pleased to have our moderator, Donna Shalala, here with us. Donna was the longest-serving HHS secretary in history, and she is not tired at all. She continues to serve in a range of critically important public leadership roles, including co-chairing the recent Commission on Care for America's Returning Wounded Warriors. So it was no surprise that she was recently named one of the 25 finest public servants of the last 25 years. And you're going to hear shortly from another recipient of that award, Alice Rivlin, on the next panel. Dawn is now serving as president of the University of Miami, and she remains actively involved in Brookings activities. And hopefully, Donna, that's going to include more work with us here at the Engelberg Center. Joining her is Dr. Michael Porter, professor at Harvard Business School. He is a leading expert, if not the leading expert, on business strategy, not just in healthcare, but in the application of competitive principles to social problems such as the environment, corporate responsibility, and, of course, healthcare. He has written one of the most widely cited books on real healthcare reform called Redefining Healthcare, Creating Value-Based Competition on Results. I'll also have on the panel Dr. Don Berwick, who's the president and CEO of the Institute for Healthcare Improvement, one of the most visible and effective organizations in the country to actually get out on the ground and get to more reliable, effective care in healthcare organizations. Don is also one of the nation's leading authorities on healthcare quality and improvement issues, and he's got a typically busy today. Right after this event, he's going to the press club to announce the initial report of the National Priorities Partners, an effort to bring together momentum around a core set of critical goals for improving our health system and our health. And then finally, not least at all, is Dr. Carolyn Clancy, who's the director of the Agency for Healthcare Research and Quality. She is a specialist, an expert, nationally recognized leader, not only of the AHRQ, but also in this entire field of improving healthcare quality and patient care. I've had the privilege of working with Carolyn and working with some of our staff here at Brookings and providing the infrastructure support for the Quality Alliance Steering Committee, a public-private effort to make available better, more consistent, and comprehensive information on the quality and cost of care. So thank you all very much for joining us, and Donna, let me turn this over to you.
Thank you very much, Mark. We have a very tight assignment. At this moment, somewhere probably in this city and in Chicago, some young staff person is assembling a book which most people in this town call Promises, Promises, and it's every darn thing that the president-elect said during the course of the campaign about a variety of subjects, but particularly about health care. And then sometime early in January, that book will be broken up, and the new secretary-designate will be handed the section on health care, and they'll look at it and say, he didn't say that, did he? The president will bring more focus to all the darn things he said by saying to the secretary, and every president does this, I'm going to run for office again in about 3.5 years, so you figure out what in this book you can deliver that I can run on, simultaneously take a very careful look on what we can do about fundamental health care reform. For most Americans, and for most politicians, with Senator Baucus being an exception, when they're talking about health care reform, they're talking about coverage. How can we figure out a way to get most Americans covered? You heard from Senator Baucus, and you will hear this morning, particularly in this panel and the next one, that the rest of us are not simply talking about coverage. We're talking about quality and cost. What do we know that the president-elect could implement now? What requires legislation? And what requires more long-term study? This is a very pragmatic season for those of us that have worked in the vineyards for so long on health care reform. And this panel, in particular, with three distinguished panelists, will talk about improving how health care works and what we know and what we don't know and what we would specifically say to the new president-elect and his team. So let me start by asking Michael Porter to speak, and then Don Berwick, and then Carolyn Clancy.
Thanks so much, Donna. It's very exciting to hear the Senator and to hear this hopefully momentum building for fundamental changes in our healthcare system. And I think the point that the Senator made is really the starting point for what I'd like to cover in my very brief introduction. We know that universal insurance is a fundamental and important goal for a lot of reasons, but we also know that it's not enough. We know that even if we have universal coverage, unless we get the system to deliver more value, better health outcomes per dollar spent, that fundamentally we will not have reformed the system and we will not succeed. How do we know that insurance is not enough? We know because as we look at Sweden and Germany and Finland and other systems around the world that have achieved universal coverage, they have persistent, difficult problems of value. Everybody's worried about value, whether you've got universal insurance or not. How do we dramatically improve the value that we deliver in the healthcare system? Well, we're starting to learn more and more about that question. And what we've learned is that it's not going to be because we make incremental changes. We're going to have to restructure the way we actually deliver healthcare. That's going to be complicated, but that's the only way. We can't just kind of tinker on the margin. We actually have to restructure the way we deliver care, the way we measure care, the way we pay for care in order to achieve this goal of dramatically improving value. What does that restructuring look like? What are we starting to learn by seeing the most excellent organizations, by seeing the leaders, the pioneers in this field? First of all, we're learning that value must be the goal, not reducing cost. There's a trap. If you start the exercise to try to reduce cost, you'll actually raise cost. You've got to start the exercise actually by trying to drive improved outcomes, because only improved outcomes actually lower cost. That's kind of one key message. Second key message, we know that the actual delivery of care must be reorganized. The way doctors and nurses and others practice medicine needs to be reorganized. We have to move from a silo, intervention-based, specialty-based system around the integrated care for the patient's medical condition, which stretches not over any one intervention but over the cycle of care. I call this new model the integrated practice unit, where we put in one organization the responsibility for the total cycle of care for the patient's problem, with one administrative infrastructure to schedule the appointments, with all the skills necessary to deal with the problem as well as the complications and the co-occurrences. Many of the most leading organizations in America and around the world are moving to this model. It's not easy, but we know we actually have to reorganize care delivery. Third, we have to change reimbursement. We've already heard this morning, we can't reimburse the way we do now. We have to reimburse in a very different way, and I think what we're starting to understand is we have to reimburse by paying for the bundle of care, not the discrete services. We need to pay for the care for a diabetic over a period of time, not for all the discrete interventions required to deal with that diabetic's illnesses, which would involve nephrology and endocrinology and education and testing and a variety of other interventions. We've got to move from discrete service intervention to bundle reimbursement for substantial parts of the care cycle. That's the only way to get everybody on the same page, to encourage efficiency, to drive improved outcomes, to avoid paying for mistakes. We have to change the reimbursement model. Fourth, we need to actually measure the value that's being delivered. There's a growing understanding that we can't improve value unless we actually measure value. And we've had some good experience moving down that path. We'll hear, I'm sure, from Carolyn about the very important steps that have already been taken to start to measure processes of care, adherence to guidelines. But the real kahuna here is actually to measure the outcomes of care, how well the patient actually does in terms of their health and the sustainability of that health over time. That's a challenging goal, but we've done it in some areas like transplantation and in vitro fertilization and cardiac surgery. Where we do it, it really works. So we have over time to achieve a system where we actually have mandatory and universal measurement of outcomes. We've got to open up competition for patients in order to drive a reduction in the hyper-fragmentation of service delivery. Right now, we have every hospital providing every service, at small scale without the experience and expertise required to do it really well. We need to open up competition for patients and reduce artificial restraints to competition across geography, across states, within regions. We've got to shift the nature of competition in health plans, and this is one of the critical links between insurance and delivery. We've got to get health plans competing to improve value for the patients, not competing to actually exclude sick people or just push down the prices for the interventions the way they're conducted today. Again, one of our big mistakes, we've been trying to push down the cost of each of the steps and the drugs required the way we deliver care today. That effort has failed for 20 years. We have to move beyond that. And finally, to improve value, we're going to have universal adoption of electronic medical records. And I think the shape of what those records need to look like and what they need to accomplish is becoming more and more clear. The urgent need today is to set standards. We have to define standards for what information means, standards for treatment, standards for interoperability, so that we can lock in on a set of standards which will allow us to drive electronic medical records going forward. These are some fundamental steps required to redefine the way we deliver care and ultimately improve its value, but the context and the policy environment today is not supportive of many of these steps. In fact, it's working orthogonally to that. So the challenge we have is how to put in place a series of policies that not only achieve universal coverage, but also at the same time create the context, the incentives, and the environment which will allow this restructuring of the delivery system. That's fundamentally the challenge that I believe is before us.
Thank you very much. Don?
Thanks, Donna. Thanks, Mike, and all of you for the chance to join you. Mark, I really appreciate the chance to be here. I'm going to make brief comments on some very complex terrain, and then perhaps we'll return to it in question and answer. Everyone agrees that we can't get where we need to go with coverage without restructuring care. Let me add a little more texture to that idea. I think it's helpful to think about restructuring as not one problem but two. And they're not the same, and they're not equally difficult. The first is removing defects from the care that people get when they're sick. Some of the statistics that Senator Baca cited and that Mark mentioned recite the overwhelming evidence we have that when you're in a hospital or in care in our country today, things go wrong. The Institute of Medicine in 2001 gave the aims more granularity by defining 6 goals for improvement: safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. That's a canonical list of defects or aims for improvement: safety, stop harm; effectiveness, align care with science; patient-centeredness, give patients more power when they are sick and need to be in control; timeliness, reduce delays; efficiency, reduce waste in the care process; and equity, largely close the racial gap in health status. The gaps are enormous. They're very persistent, but there's a lot of good news, which is that through the work of many organizations, we now can see healthcare improve with respect to care of the sick dramatically, but in pockets. It's not universal. The problem here is not feasibility, it's comprehensiveness. Let me give you a couple of examples. I got an email last week from a small hospital in upstate New York that we've been working with in our 5 Million Lives campaign, Claxton Hepburn Hospital, it's called. They've gone 4 years without a single ventilator pneumonia. When I was in training in internal medicine, I thought ventilator pneumonia was inevitable in maybe 1 out of 10 ICU patients. 4 years and not a single case. Mayo Clinic, really the leader in American medicine, in my opinion, in quality in so many ways, has reduced its error rates by 50% in 2.5 years. And that's documented, measured results in all 3 of their flagship sites. The Medical College of Georgia is a heroic place in Augusta, Georgia, which is changing the whole landscape of patient-centered care, and breaking all the rules and putting patients and families in power like they never were before. Owensboro Medical Center is a turnaround. It's in Kentucky, a small critical access hospital that I heard a report from a couple of weeks ago. They're working with us also in our campaign. 30% reduction in all-cause mortality and a list of complications almost eliminated that would take your breath away. So it is possible to improve care. There are savings from that, especially organizations that get involved in lean production, the Toyota production process. They're showing you can save substantially in care while improving the well-being of patients. The barriers are enormous. There's toxic payment mechanisms that Mike mentioned that Senator Baucus referred to. They've just got to be removed. We've got to stop the possibility that you can make money on defects. It's not true in other industries. It needs not to be true in healthcare. And there are very serious leadership challenges. We actually haven't trained medical or lay leaders, especially in the acute care community, to lead quality. It's not in the curriculum. And so there's a lot of retraining going on as people begin to understand that's important. That goes right to the boardroom, because hospital boards have never before felt responsible for what happens to patients in hospitals, quality of care. They're responsible for the economic well-being of the hospital, but not necessarily for care. That needs to change. I'm very optimistic about that. I think we can align things right, and I think we can move from pockets of excellence to generalized excellence with some smart policy. But it won't solve the problem, not the second problem, not the big problem. The big problem of value that Mike refers to. I disagree slightly with Michael, although it's only because I'm wrong and haven't understood him thoroughly yet. But I also think the problem is cost. It's total cost. It is manifestly possible for a Western democracy to give all the care its population needs for about 10% of the GDP. It is possible. You can't say it's not possible because it's being done. We're at 17% or 16%. We're wasting probably 40% or 30% of the dollars we're putting into health care. That's true, and I don't understand, Michael, I know come back at me on this, and why we just don't target that as an aim, reduce the total cost. 30% waste easily in our system. I think he wants to get there by working on quality and value, and that's probably right, but don't take your eye off the ball. In the Institute for Healthcare Improvement, my organization, we put on the screen something called the triple aim. The triple aim refers to improving care, like reducing defects, improving the health of the population, reducing the obesity and violence and depression and social generators of ill health, and reducing per capita cost, all three at once. Better health care, and lower per capita cost. And Michael's term of integrator is exactly the same one we use. We need responsible organizations in the country to emerge who have the triple aim as their duty. You can't fragment these three. You end up with sub-optimization, and you don't square the circle. The gaps with the triple aim are absolutely enormous. The reasons are complicated and won't fit into the couple minutes I have left. But first, the biggest, probably structurally, is supply-driven care. It's what Elliot Fisher will be telling us about in the next panel. We simply have a toxic dynamic in healthcare that if you make something, it will be used. No other market really works that way. And maybe if we got good advice from Michael and others, we could get rid of it. We have to target supply-driven care as a matter of public policy. It's very, very difficult. The second is integrated care for chronic illness and the gaps therein. The Commonwealth Fund is now our lead, scrutinizer of that problem. 70% of costs go into chronic illness care. Probably half of it is pure waste. And a lot of it happens because we don't have the integrated flows that we need in a restructured care system. The third really might be American exceptionalism. It's our inability to learn from successful models outside this country. Countries that function with better care than we have. We're 19th out of 19. That's in the OECD data. That's what Senator Baucus said. He's right. Compared to countries that are functioning at 60 or 70 cents on our healthcare dollar. We've got to learn from these other models and not throw them away because we assume that stuff like that doesn't work here. It will. It's our decision. What we choose, we can choose to change. The problems and barriers are enormous to get at this waste and the triple aim. There's oversupply of services we don't need. There are handoff failures and duplication of effort everywhere because we don't have integrators of care. There's poor use of capital, misallocation of roles, poor end-of-life care, weak coordinated functions, and massive underinvestments in prevention. In a triple aim world, hospitals would try to be empty, not full. Elliot Fisher would be happy. We wouldn't be driving care with supply, and patients would feel remembered. I've got some political advice, but I think I'll hold that for later on.
Thank you. Reassuring, I just bought a hospital, right?
Good morning, and
Carolyn.
I, too, am very pleased to have this opportunity, particularly looking at the substantial intellectual capital in the audience here. And, Mark, I couldn't let the moment pass without saluting your leadership on all of this. So I think the Center for Healthcare Reform is only going to do fabulous things. Senator Baucus started off by reminding us about that famous study from the RAND Corporation that said that Americans receive recommended care a little over half the time. That was in 2003. And over the past 5 years, we have seen steady incremental improvements. That would be the good news. And a lot of this, I would argue, and I think others would as well, that this is in response to a strong focus on transparency, focusing on quality measurement, putting it out there, and frankly, a lot of providers taking this to heart very seriously. It is not yet consumer friendly. The slightly less good news is that our pace is modest, if not glacial. And it isn't going up, improving at anything like the rate of our constant increases in costs. So last year, we report to the Congress every year on quality and disparities. Last year that we found across all settings and populations, as a nation, quality improved 2.3%. Now, if your starting point's 55, I'll celebrate any momentum going forward. But at that rate, it's going to take us, my statistician told me, 18.994 years, he's a precise guy, to close the gap between best possible care and the care that's routinely provided, and we can't possibly afford it. That same year, expenditures went up 6.7%, and that disconnect anyone can get. You don't need to know the technical specifics of how to measure quality and so forth. We're simply not getting the return, so I'm agreeing with my colleagues with a great deal of enthusiasm. There's a lot of talk in terms of improving the cost equation by looking at the concentration of health expenditures. Where do we spend the most money? And it turns out, if you think about that in quality terms, there's a pretty high degree of overlap and congruence. And where that is, it's for people with chronic illnesses. In the Medicare population, we see that the 20% of patients with the multiple chronic illnesses are the same 20% that incur about 72% of the expenditures. So if we could focus our efforts there like a laser beam, we've got a lot of improvement to do. That has to be coupled with two additional themes. One is eliminating disparities in care associated with patient race, ethnicity, education, and income. We've known about these for years. I think we've taken it as background noise, and we're seeing now that we can do much better. And the third piece of this, no matter what happens with chronic illness care, when people are in the medical care system, they're there, that's a tiny, tiny proportion of the time they live with that illness. They manage it at home. So we've got to be seriously focused on engaging consumers in their own care. So again, if you focus where we spend the most money and provide the worst care, I think we can achieve what my colleagues have described in terms of improving quality and value in healthcare for much less costs. So to make this tangible, let me give you a very explicit example. This past year, we've been working with the Administration on Aging, part of HHS, in 8 communities to reduce disparities and improve care for Hispanic elders. So this includes Chicago, Houston, LA, the Lower Rio Grande area, Miami, New York, San Antonio, and San Diego. Within each of these communities, we are working with the clinical care providers and with the area agencies on aging. So in other words, you're connecting the care delivery system with community resources or boots on the ground to actually help people with the additional steps that they need to take to make sure that they can manage their own health and health care effectively. So in New York, they focused on helping Hispanic elders in East Harlem and the South Bronx manage their diabetes after reviewing the data from our report, which had been drilled down for them in their community. So that was one piece of good news, that we could actually develop data-driven, evidence-based interventions and apply it at the community level. The second piece focused on the consumer engagement. A number of years ago, ARC funded Kate Lorig from Stanford to develop a diabetes self-management training program. And she learned something that's really, really important. It is not about how much people know. It's about their motivation and their belief that what they do makes a difference. She's gone on to work with many, many systems in healthcare. Right now, through this same initiative in these 8 sites, that same intervention is being improved and modified just a bit so that it will qualify for Medicare reimbursement as for diabetic teaching. This is an area where every year CMS allocates resources, and yet they don't have enough certified programs to actually be able to invest. So we know that we can do it. So Donna had challenged us to think about short-term and long-term actions. The first is that under Mark's leadership, there were many exciting demonstrations done in CMS. I would say they have 2 flaws that could be easily fixed administratively. One is they're not multiple payer. And the same providers see patients served by or whose services are paid for by multiple different insurers. That's one step that would make it easier. They have to move much faster. I'm sure if we had another infusion of Mark's energy, we could do that. That is not a game changer. That could happen very quickly. At the same time, I think that we're going to need to couple that with a space for some changes in payments. Right now, if doctors and hospitals decide this is it, we can improve dramatic care to get to Olympic class, as Don often says, tomorrow. The bottom line is they lose revenue immediately. Now, no one gets up every day to think, gee, I need to keep my bills paid, so I think I'll provide not so great care. But what that also means is that they don't have the resources to invest in the nurse case manager or other outreach resources to help people with chronic illness do better. And I think that we have to get very, very serious about consumer engagement. It's not just for those with the sickest patients who are showing up in our reports. It's also very much about getting to kids early in school so that they understand that they can play a very active role in their health and health care. No one with chronic illness actually wants to be thinking about their illness all the time. What they want to do is get on with their lives. And I think if we give them the tools, we can do that. So let me just say that last week my boss asked me, what were the game changers in improving quality and so forth? And I told him, as far as I could see, two things. One is data-driven, evidence-based improvements, but that means feeding back information to those on the front lines in something close to real time. Where we've seen dramatic improvements, that has been a consistent theme. And the other is creating a space and cultivating the consumer's voice. When powerful, articulate consumers step up and say, it doesn't have to be this way, it has an astonishing effect on policymakers, providers, and so forth. They all say, you're right, yes, we can. So, Jim Guest, I'll salute your efforts with Consumer Reports, and we need more of it. Thank you.
Thank you very much. Thank you very much. Three very insightful commentaries. Since Carolyn started the process of telling President Obama exactly what he should do at CMS, for example, let me ask Michael Porter, if President Obama appointed you as head of CMS, what are the 2 or 3 things you would do immediately, considering the fact that you would have control of the rules that apply to Medicare and Medicaid? What would you do to try to get to what you've been talking about?
Well, that's a dangerous question to ask a non-Washington insider because I have no idea what's feasible. But if I were going to try to cut into this, I would, first of all, I would start pushing very, very hard on the measurement of outcomes.
Okay.
And start to make that process not a bubbles up, it's going to take 100 years, we're going to fight over everything kind of process, but a process in which there was a group established charged with that responsibility with a time frame that we could get that done. A second thing would be to start very accelerating the reimbursement reform around bundle pricing. Okay. We've been fighting for years whether doctors should get paid separately from hospitals. The answer is no. It's stupid. It's idiotic. We've got to get on with that. We've got to put the inpatient and the outpatient reimbursement together. And that requires some heavy lifting in terms of defining what service bundles are and how long those service bundles should cover. But I think the bundle reimbursement will drive so many other things. If the reimbursement is bundled, the care will then almost naturally be forced to be coordinated and integrated. The resources expended will be thought of carefully across the various specialties and interventions. The need to reduce complications that you have to bear out of your own pay will all of a sudden be acute. So I think those 2 areas are kind of frontline areas. And then there's some very artificial stuff that's getting in the way of integrating care and coordinating care, like Stark laws, which are well-meaning but intrusive, like corporate practice of medicine laws, like state licensing laws, like cumbersome licensing process. So there's some smaller things that are big, but they're smaller. The big kahunas, I think, are the measurement and the reimbursement reform.
Great. Don?
I agree with what Mike said. If you take my 2-part analysis, defects in care and then population-based care, on the defect side, I agree with Mike. We need more transparent outcome measurement. A lot of the measurements that are floating around in CMS and elsewhere are way down in the process and particulate level. We just need to know, do people live or die, what are complication rates, and move transparency up to outcomes. Hospitals also need help. I think one of the mistakes in public policy underway right now is the weakening of the good part of what the quality improvement organizations intended to be. We need like the Agriculture Extension Service in agriculture. We really need that in healthcare. So hospitals can get, probably under federal sponsorship, the kind of technical support that actually they can start to get from AHRQ if we beefed AHRQ up and supported a robust new QIO structure. We need goals also. A president needs to articulate some goals. The IOM laid out safety, effectiveness. Why don't we have a White House that says, now let's get here country on safety, effectiveness, timeliness. On the population-based side, it's much more difficult politically. The amount of money on the table is enormous. I mean, we're talking here about gain-sharing opportunities and recoveries that would be, Paul O'Neill's saying $1 trillion. I don't think he's that far off, actually. It's hundreds of billions accessible if we could move back to population-based care management. We lost it in the country. We tarred the concept of managed care with all sorts of garbage. But the core of the idea is correct. The old managed care idea that Paul Elwood articulated, that started Kaiser Permanente, that started group health, is still correct. You take care of a population and pay a caregiver for care of the population with a limit. That's going to require emergence of integrated care. Medicare should do that. Medicare Advantage is not working right now. It's been grabbed a hold of by forces that don't understand true care integration, but somehow we have to get back to that. My wife is Undersecretary for Energy in Massachusetts, and she has taught me about decoupling in the energy world, where utilities now in at least 20 states or so aren't paid for volume. They can make as much money by saving a kilowatt as by making one. We need to do that with care. You ought to be able to somehow treat an empty bed as an asset. Right now, we don't do that at all.
Mm-hmm. Carolyn, I'm switching you from AHRQ to CMS.
Sure.
In the new administration. What are you going to do first?
Well, I'd like to just build on this idea of rapid demos with multiple payers. The reason I think we need that is any effort to improve quality and value that's national, by definition, limits our ambitions, because it has to be available and easy for all, or at least possible for all providers to participate. And what it doesn't create is any space for Olympic-class performance. And the kinds of potential savings that Don is talking about, I think that we could accomplish at a state or regional level. What this would require is that we stay away, or that we move beyond our thinking where we don't want to contaminate one demo site with another demo site. So health IT's got to be in a separate place than another one focused on improving hospital care, physician group practice, and so forth. We need all of it. And I don't think that this is beyond our collective experience. I see Senator Whitehouse nodding here. He's been doing this in Rhode Island before he came to the Senate. We know how to do this if we create the space for it to happen.
Great. Let me pull the audience in and see what questions you have for our panelists. Questions? Yes, back there. Yeah.
Dr. Porter, if I understand some of what you've written, part of what you call for is...
Why don't you identify yourself?
I'm Alan Weil.
Right.
And I now have a microphone. I'm Alan Weil, Director of the National Academy for State Health Policy. Dr. Porter, if I remember some of what you've written, part of the implication of your thinking about the financing is to eliminate the ability of basically discounting as a technique for competitive advantage from the payer side. I hope I understood that correctly. And so help me, and with Dr. Clancy's comment about multi-payer, this whole notion of moving to value and aligning different payers. If we did move away from discounted negotiations as a fundamental basis for competitive advantage, that would have big regulatory implications, big fiscal implications as we think about the changing payments of Medicare and Medicaid. So could you expand on that component of the agenda for transparency and competition for value?
Well, that's a very complicated question and could be punted in terms of if I were trying to implement, a series of reforms. The basic idea is that right now we sort of assume the interventions as given, that the patient's going to go have all these visits and they're going to have all these treatments and they're going to have all these tests, and we try to beat down the cost of each one by limiting doctor payment and reducing the fees for this and this and this and this. And so the first key point is that just beating down the cost of each of the interventions, assuming that they all stay the same and they're as complicated and convoluted as they are today, that may help, but it's not going to get us to the goal line. We've got to rethink the whole structure of what sort of interventions over what period of time. The other thing that comment picks up is that when health plans get a lower rate because they have a bigger population of members, that actually doesn't really increase the fundamental value being delivered. That just means that it's a bargaining power game. And it's that bargaining power game that's gotten us, in many ways moving in the wrong direction in terms of the nature of competition. So the problem we've had is health plans have competed on excluding sick people and using their clout to bargain lower prices for the same old services that we deliver. And I argue that actually isn't driving value. So what we need to do is eliminate the ability of health plans to compete on selecting out sick people. We have to end that so that they have to take their fair share of everybody. And then we have to get them focused on competing on value, improving health outcomes per dollar, not just beating down the price for the same old care. That's the idea. And there's various ways to approach that. I believe the best way would be some kind of fundamental reimbursement reform, again, with a bundled pricing model. I'm a little bit hesitant to go to global capitation, to pay a provider group to deal with any possible problem a patient might have. I have very comfortable with the idea of creating a very different reimbursement structure for primary care, which has certain limits drawn around it, that will incent primary care providers to do a great job and maintain the health of the patient. But I think once a patient then gets into being a diabetic or having congestive heart failure, then I think we need another capitated model for the care of that condition over the cycle of care. And I think it's a mistake to make care providers into insurance companies. So that's an area where Don and I perhaps have a difference of opinion.
Don, do you want to follow up on that point? You're really talking about two different pricing because of the complicated business of trying to price the acute care, I take it, to price the package, whatever you would pay the capitation.
Well, I think that let's take, suppose you have breast cancer.
Right.
I would argue there should be a bundle price for the care of a breast cancer patient with a risk adjustment for the stage of the disease and severity of the disease. Mm-hmm. And that should cover the whole process of care, which is going to include some surgery, some chemotherapy, and some other interventions. It's going to involve some inpatient stay, some outpatient stay. Again, we do that in organ transplantation, believe it or not. There's a bundle price for a kidney transplantation. That includes pretty much everything. That was driven by Kaiser Permanente saying, we want a price. We just don't want an open-ended thing where you just do whatever you want and charge us for each service. That model, I think, has been a great model in really driving a greater sense of value improvement in that area. So it's that.
Well, it's also made that area a cash cow because people have figured out that that's a very nice payment for what they do. Every transplant center I know makes a lot of money.
Well, but so then we ought to have competition, which starts then to say, okay, let's let that bundle price go down. And measure very carefully the outcomes. The nice thing about transplantation is we have universal outcomes for every one of those centers. So we can now start the value-based competition at work. But without the reimbursement model that gets all the services bundled together and gets the provider organization to think about how can we produce the best value across all these services, then I think ultimately we're going to be flailing away here.
Don, do you want to get into that a little bit?
Sure. First, let me say I have enormous respect for Michael's work and gratitude for his entry into healthcare. It's going to help us more than almost any other intellectual contribution we've seen in the decade. It's a tremendous gift. But I don't totally agree on two things in particular. I do not have Michael's skepticism about the lack of wisdom in uniting payment and delivery. Mm-hmm. I wouldn't use an insurance model. The concept of insurability is over. We now can predict people's fate, and actuarial calculations don't apply anymore. I would like to give providers of care a pot of money and say, here's a group of people, please take care of them, and do it under scrutiny, and maybe have some competition around that. But I am not suspicious of that. And some of the best care we have is of that type. And in Europe, where the care is better than ours, in many respects, that's how care is often funded. But I don't know. Maybe we need two kinds of experiments and see how that sorts out. With respect to sectoring off specialty care, Michael's model involves designating a patient as having a certain kind of need, breast cancer or maybe heart failure or heart care. I don't think that's how patients come packaged. I think the needs of the average chronically ill people are very protean, they're tentacular, and I think it's better to put it under the same roof. Now, of course, an integrator, and we badly need integrators, this intermediary, which I would have be the old version of managed care, will have to contract with specialty services. And there might be competition. There might be a breast cancer service of the type Michael imagines that's trying to win business through value. But I wouldn't divide the patient into parts. I don't think that's very wise.
But,
yeah, I would just...
Why don't you take your microphone off and come down here so I can integrate this discussion a little bit better. You want to comment on that, and then I'll take the next question.
Sure, thank you. So I wanted to make just two quick comments. One was building on your point, Don, about how bundleable our patients' needs. If you look at chronic illness, just under 10% of people with diabetes have only diabetes. That is to say, there are the vast majority have several conditions, and trying to figure out how we would create multiple pathways, I think, would be a little bit challenging, and I'm not sure we could find one. I love your idea of expanding the role of primary care, but in full disclosure, I am a primary care internist by training. But I would also say that you can't have a medical home unless it's in a friendly medical neighborhood. And I think our big challenge is going to be to find out, can we replicate some of the clear advantages in performance that we've seen from some of the best integrated care delivery systems with delivery systems that are virtual. I think we can do this. I think this is frankly how concierge practices do it. And the question is, what's going to be the integrating function to do that? But if you look at some of the Medicare patients who see 37 different doctors in a particular year, it is beyond my imagination to imagine that they have a common game plan or a shared idea or a shared script for what ought to be happening with this patient. And then it's not surprising that we have so many opportunities to reduce waste.
Yeah, I should point out I'm from Florida, and the providers have a common game plan. There. Let's take the question there.
Jack Lewin, American College of Cardiology. Dr. Shalala, great to see you. Four heroes up there on the stage. Appreciated your comments very much. I'd like to ask a process question, if you will, for the CMS administrator out there. In that, I think that we want to get to this outcome measurement idea is where we need to go, and it's very exciting, and there are some good signs about how we can get there. But it appears that we lack a business case or the strong enough carrot to actually get people to move in that direction, even though we're looking at integrators and trying to change the delivery system around having multi-specialty approaches and hospital physician approaches. What do you think about the idea of putting something as a step in the direction of a significant increase in reimbursement for, say, electronic reporting through an accredited registry that actually collects all the guidelines, performance measures, science we have today as a step towards getting that information and moving toward outcomes? My fear is that we will be kind of putting little steps together around the edges and slowing our progress. In cardiology, I mean, if you just look at there's probably $180 billion in Medicare of cardiology services. And a lot of that service relates to those 20 to 30% of heart failure admissions who come back in 30 days. If we just reduced by 10%, those heart failure readmissions, we'd have enough money to put a 7 or 10% increase for every service for those who took that step. So I think we need a business case and a step for the administrator to move us from where we are to where we have that data and can begin to measure it. Any comments there, please?
Let me have one of them answer so I can get around to the questions, and then we'll have a final discussion. So, Carolyn, do you want to?
Sure. Jack, I think given where we are in healthcare delivery today, that would be a giant step forward. I would also say it's necessary but not sufficient. I mean, today we have patients getting technically excellent cardiac care who either don't get the point or have other challenges taking their medications, which may be cost, may be side effects, and so forth. So I think that we've got to have a commitment to outcomes. And what I would prefer is that we had a coherent approach rather than simply trying to ding hospitals for potentially avoidable readmissions, which I think is a good tactic, but it's not a strategy to figure out how do we actually get to what we want to achieve.
Okay. Right here.
William Hazeltine. I'm just finished through my foundation a study from the Rockefeller Foundation, supported by them, administered through Brookings, on efficiencies in healthcare delivery in India, a number of experiments in India. And one thing I hadn't heard discussed very much is dramatic improvements in process. Their heart surgeons do 10 times as many surgeries per day and per year as ours do. They use their heavy equipment 5 to 10 times more heavily. They rely on a completely different structure of manpower, de-skilling, and changing the way manpower is used to drive costs down. If we implemented those systems, we could probably save 50 to 80% of our costs. I think it's well worth looking at those kinds of innovations, which I have not heard you guys discuss, really radically changing process, using high technology, and getting the kinds of outcomes we expect. They do this with getting high-quality outcomes. And if we did that, I think we could make a major change. And I haven't heard that kind of radical restructuring of process discussed in any coherent way.
Right. Thanks, Bill.
Well, there's a very large book that has a little bit on that in it. But the basic idea is that right now we deliver too many services in a very fragmented way, with not very much volume, with not very much scale, for a given set of services. And as a result, we don't do it very well. And we're not utilizing equipment and facilities. We don't think about how to de-skill because we don't really have. It's a hyper-fragmented system we have in this country. So I think one of the things that you're absolutely right, that one of the fundamental things that has to happen is we can't have thousands and thousands of hospitals all offering exactly the same services, even if 10 of them are in the same city. That model of doing things at a very, very small scale really drives us to the inefficiencies that we see in many of the processes.
Just to make a quick point, Denver Health, a public system, has done this. They've brought in experts from other industries, and they have managed to continue to improve quality, which was already very good, and make even more rapid improvements and to save the system money. So and they take care of some of the sickest patients in that community. So we know it's possible, but I think our reimbursement system has to actually give some rewards for doing that, because right now it's kind of an act of altruism.
Yeah, Don, you've written on this too.
Yeah, I mean, Bill's right. It's all about process. It's all about design, whatever aggregate level we're talking about. As long as we have an industry that can make its primary business plan revenue increase, people aren't going to be interested in process.
No.
Ellen Siegel, Friends of Cancer Research. So in this really important discussion we're having, there seems to be
microphone closer to.
I'm sorry. Can you hear me now? There seems to be an absence of research and the impact of research. So as an example, even in the model you're talking about with breast cancer, we certainly don't know how to prevent it and often treat it. And we're talking about personalized medicine, how does that fit into this discussion? Because that's really the future of getting better and more effective treatments that are personalized. And that seems to be absent from the discussions.
Sure. So, recently there was an article in Newsweek called The Valley of Death, and it talked about the drop-off from biomedical breakthroughs to actually developing patient interventions. And I actually think there's a second valley of death that we need to pay attention to as well, which is all of the research that we have funded that takes way too long to actually get translated as patient benefit on a routine basis. So, as we make advances in health IT, I actually think the delivery system can be a platform for discovery as well as for providing superb care, and I think we should hold out for nothing less.
Last question.
Larry Minix with the American Association of Homes and Services for the Aging. Dr. Clancy, you mentioned you can't have a medical home without having healthy neighborhoods. Any of the panelists' thoughts about how we move from the silos of care and service delivery that are in every rural and urban setting in America to creating networks of care and service that make the delivery much more seamless? How do we incentivize communities with providers, business, consumer groups to create that sort of a more seamless approach to ongoing care delivery if home can be more of the center of care?
Don, why don't we?
I can't think of a way to do it without population-based care designs where someone at whatever community level you're talking about is responsible for the care of a community, a population of patients. It could be all the employees of a company. It could be the citizens of Massachusetts. It could be the people of a certain demographic. But until someone says, I've got your back to a population and I have a budget to take care of you, I don't think I can get that care integrated the way you're talking about.
Yeah. Let's thank these three remarkable health leaders.